It's usually the blue intravenous catheter, so the size, I think it's a size 23 catheter, the blue one.
Какой объем контраста нужно вводить? Ну, для контраста.
Yeah, about 2 to 3 milliliters, 2 to 3 milliliters of the contrast.
Насколько вы устанавливаете дренаж после мукоцели, когда вы оперируете рану?
Okay, we keep the drain in until the drainage stops. So if we have the drain in and when we see the animal at a post-op after 3 days and there's no drainage, we might remove it. If there's still drainage, we would see them 1 week later. If it's still continuing to drain, we might leave it a bit longer. But as soon as the drainage itself will stop, then we would remove it. We expect that the drainage is going to stop soon because we only want the residual saliva that is in the tissue to drain out. There should not be any additional saliva being produced that will cause a continuous drainage.
И последний вопрос. Как вы дифференцировали, вот белого пуделя вы показывали, что там была опухоль жировой ткани от новообразования слюнной железы скуловой? Спасибо.
The diagnosis was based on histopathology, so they took a sample of the gland. I cannot remember if they actually incised that gland or if they did a fine needle aspirate, but a sample was taken and the diagnosis was made of the fatty tumor before the surgery was done.
Здравствуйте. При удалении подшелюстной слюнной железы всегда ли вы открываете капсулу? То есть, если, например, подозрение на неоплазию идет.
Okay, I think that what we do is that we would base the surgery on the diagnosis. So if we have a diagnosis of neoplasm, then we might need to include the capsule in the excision. If we have a sialosul where it is an accumulation of saliva as a result of trauma, then we would normally leave the capsule there and remove the gland only. So it depends on the diagnosis. If we have a diagnosis of cancer, yes, we must take a wide margin.
Каким образом вы удаляете камни из слюнной железы? При помощи чего? Можно ли это сделать консервативно, промыть, например, железу? Или нужно обязательно вскрывать проток?
If there is a myositis in the punctum, so right at the opening, and there's no other trauma, then it is possible to gently open the punctum itself, maybe with a scalpel blade, and remove the stone. If the stones are in the gland, you have to remove the whole gland, because you cannot go in and remove separate stones inside the gland and hope that you will resolve the problem, because we will cause additional trauma. So if the stone's already in the gland, we need to remove the whole gland. The same goes if we have a situation like we had in our clinic once where the salivary stool was so long-standing that there were already sialoliths that formed in the stool as well. In that case, you have to open the stool and flush them out and keep it open to make sure that we get them to drain out.
Еще вопрос.
Спасибо. А какой шовный материал вы, как правило, используете?
Suture material that I use as a rule is a monofilament synthetic absorbable Ethicon suture material by the name of monocryl. And the monocryl that we use will be in some situations a 4-0 and in some situations a 5-0. But it's our suture material of choice. If we're going to do ligatures, we will use the same suture material. So if we have blood vessels that we have cut during the procedure, we will ligate with the monocryl, and then we will do usually 3 layers of closure, one in the soft tissues, one intradermal, or one subcutaneous and one intradermal. So we try not to put sutures through the skin.
Скажите, пожалуйста, а вот как вы диагностируете сиалолиты? Рентгеном или КТ?
I think CT is probably going to be our diagnostic modality of choice, because then you've got the 3D potential to see where the stones are. But if you take a radiograph, you can see that there are stones there, but you cannot tell where they are. So yes, CT is a better diagnostic modality.
Спасибо большое за лекцию. Скажите, пожалуйста, а всегда ли при мукоцеле необходимо удалять железу? Спасибо.
Yes, if the saliva is sitting in a subcutaneous area or in the other tissues, then it is necessary to remove the gland. I think the only time that we might not remove the gland is if we have a ranula that is underneath the tongue, and we can do marsupialization. Sometimes marsupialization is sufficient to cure the problem, but in some situations we can do marsupialization, and then 1 month later the ranula is back again. In that case, then we will go and take the salivary gland out. If marsupialization gives us a good result, then we leave the salivary gland.
Еще вопросы? Так, тогда сейчас я буду задавать.